Okay, and welcome to the Davies Use Case webinar being presented by VCU Health on early recovery after surgery, a colorectal project. This is a Davies Award-winning use case for the value of health IT. My name is Arnold Simmons, and I'm Manager of Quality and Patient Safety here at HIMSS. It is my pleasure to moderate this presentation. Core to the HIMSS mission is promoting the use of health information and technology to improve the quality of healthcare delivery. HIMSS promotes and advocates the integration of clinical decision support and best practice guidance, access to clinical data to analyze progress, and information and technology enable patient safety tools for all healthcare organizations, clinicians, patients, and community members as vehicles for improving patient outcomes. The HIMSS Nicholas E. Davies Award of Excellence is the pinnacle of the HIMSS Value Recognition Program. The Davies Award recognizes outstanding achievement of organizations from around the world who have utilized health information and technology to improve patient outcomes and value. The Davies Award-winning use cases have been peer-reviewed to validate sustainable, improved patient and business outcomes resulting from health information and technology-enabled care delivery. So it's my pleasure to welcome our speakers for today's webinar, Dr. Jamie Bowl and Paula Spencer. Dr. Bowl, I will turn the presentation over to you. Thank you.
Today we're going to talk about enhanced recovery after surgery for colon and rectal surgery. We'll talk to you about the nature of the problem as well as our project's design and implementation. Paula will talk to you about the health IT utilization that we used in order to enhance our project, and then we'll go over the outcomes of the enhanced recovery after surgery for colon and rectal. Our problem in colon and rectal was that our patients had a poor experience, long length of stay, slow or stunned return of organ function and GI function, and a high rate of post-operative complications. In order to improve these outcomes, we used an enhanced recovery after surgery protocol, as our previous single-armed interventions had not significantly improved any of these outcomes for our patients. Our baseline data in fiscal year 2015 were that our average length of stay for patients undergoing a segmental colectomy was 9 days in the hospital. Patients had a 23% risk of readmission. It cost $17,000 for average direct cost, and our patients had a surgical site infection rate of around 15%. So in order to achieve our goals of reducing length of stay and surgical site infections without increasing cost or readmission rates, we initiated our enhanced recovery after colorectal surgery project. Our RAMCare project model provided the framework for our success. Established in the fall of 2011, the RAMCare program is VCU Health's standard approach to delivering clinical effectiveness through reliable, appropriate, and measurable care as represented by the program's RAM name. Projects initiated within the program set out to define evidence-based best practice clinical pathways that are supported by technology to deliver highly reliable care. We focus on the 6 domains of healthcare quality as defined in the 1999 Institute of Medicine report, Crossing the Quality Chasm. These domains are safe, timely, efficient, effective, equitable, and patient-centered care, referred to as the STEEP principles. Our approach to process improvement starts with people, then the process, then technology. It's people that make change happen, and our experiences through this and other projects have underscored the critical importance of dedicated physician champions, engaged senior leaders, dedicated time for clinical participation, and enhanced partnerships with performance improvement and our quality committees. The RAMCare program provides the framework to engage and activate interdisciplinary teams, each led by a dedicated physician and nurse champion. Our clinical teams are supported by our internal consulting professionals skilled in project management, change management, process engineering, business and financial analytics, and clinical informatics. Our care teams collaborate to reliably deliver best practice care through the redesign of complex clinical systems by embedding them into everyday workflows centered on the patient journey. Technology is then leveraged wherever possible to hardwire these processes. The deployment strategy results in a sustainable infrastructure built around staff and other capabilities through resource optimization, training and development, analytics, and IT tools. Processes and outcomes are then measured to provide feedback and continuously evaluate the effectiveness of changes introduced, thereby creating an evolutionary model of practice. Successful projects will position the organization to thrive in an environment of alternative payment models, such as bundled episodes of care that address the whole patient as opposed to an acute intervention or procedure. Our patient-centered approach is supported by ensuring the project team is comprised of representatives from all disciplines and all care venues encountered during the patient's surgical care journey. Our project life cycle is organized into 6 stages. Beginning with service line leadership engagement, champions are identified to lead the team and the team is formed. The patient population is defined and baseline outcomes are reviewed, resulting in a set scope for the project with clearly defined goals. The team convenes and reviews the evidence available from each discipline, discussing and reaching consensus on the best practices to be embedded into the care pathway. Current state processes are observed and documented. In the 3rd stage, the team outlines how each best practice will be carried out and conducts a gap analysis, identifying potential barriers to success and developing action plans to address each one. The team then focuses on designing the end-to-end future state process utilizing quality improvement tools such as PDSA or Plan, Do, Study, Act to conduct small tests of change and refine the design. We reserve electronic medical record tool design for stage 5, ensuring we have fully explored the ideal future state without influence of IT system capability assumptions. Our RAMCare team stresses the importance of the hierarchy of people, then process, then tools, to ensure we design the best technology solutions to support the desired work processes. Stage 6 is to ensure we are learning from our initial implementation and allowing deliberate time and resource for iterative improvements, building on our experience and what we learn through measuring our process and outcomes. Once a project is closed and the new system is operationalized, our clinical teams continue to monitor and assess their performance. The RAMCare team can be re-engaged for future improvement projects whenever significant best practice evidence changes or significant opportunities are identified. However, most small-scale change can be subsequently managed by the operational team. For our colorectal surgery project, the evidence base of primary focus was the collection of parasurgical care principles known as enhanced recovery after surgery, or ERAS, to optimize the patient experience and outcomes across the entire care continuum. These 22 key elements of care are delivered along the patient's journey, addressing perioperative optimization items such as treating anemia and uncontrolled diabetes, addressing nutrition deficiency, smoking cessation, alcohol and drug use, and chronic pain management. Perioperative fluid management begins with patients taking oral carbohydrate drinks prior to surgery, managing fluid balance in the OR, and discontinuing lines, tubes, and drains early after surgery. Postoperatively, the principles address early restoration of patients' baseline function in the form of early feeding and mobilization, reduced utilization of opioid pain relief, and adequate sleep. Studies show that it's the aggregation of these care elements that has the greatest positive impact, and 80% compliance is needed to realize significant improvement in both short-term and long-term outcomes. Dr. Bull will explain to you now how we utilized Health IT to achieve these goals. So Paula explains the clinical workflow of how our patients move through the perioperative setting, starting for the decision of surgery in the surgery clinic with the surgeon and provider, moving through to the anesthesia clinic, the perioperative setting, pre-op, intra-op, and post-op while in the hospital, and then upon discharge. IT was used in all of these stages in order to reinforce our enhanced recovery principles throughout the pathway. The first step is in the surgery clinic when they are seeing the provider and a decision is made for surgery. Patients are then undergo diagnostic studies to look for comorbid conditions which can impact their post-surgical outcome. As Paula mentioned, this can include anemia, nicotine dependence, alcohol use, pain management of chronic pain conditions, as well as uncontrolled diabetes. Also, upon arrival to the hospital in the pre-surgical care unit, there are order sets that are initiated by the provider and the nursing staff in order to follow our enhanced recovery principles. Patients have an IV started, but fluid not given in the preoperative surgical unit. However, they are instructed to drink a carbohydrate drink 2 hours prior to arrival in order to allow their GI or gastrointestinal function to be maintained throughout surgery. Patients undergoing surgery can lose their temperature and not thermoregulate normally, and we take measures beginning right on their arrival to keep them warm. Patients also have DVT prophylaxis, meaning we put compression devices and give them medication to help prevent deep vein thrombosis. They receive medication in the pre-surgical unit to preempt pain management, which includes Tylenol and gabapentin, and then they undergo any other necessary blood work that is needed. During the actual procedure, right before initiation, the nurse in the operating room documents some other maneuvers within the enhanced recovery bundle to ensure compliance with these strategies. For instance, they talk about whether the decolonization was used on the skin with chlorhexidine wipes and baths prior to surgery, and that the hair was clipped appropriately as per protocol. As part of our enhanced recovery strategy meant to decrease our patients' infectious complications, there is a colorectal closure tray embedded within all of the preference cards of all surgeons who perform colon resections. This includes redraping the patient with clean drapes, using a completely new instrument tray to close the incision, as well as antibiotic irrigation to reduce our surgical site infections. Also, intraoperatively, the compression hose and Foley catheter insertion is documented by the nurse. If any team members have any questions about the components of the enhanced recovery pathway that they're responsible for, they can always access this information under quick links on our VCU intranet. This is an overview of all of the different elements of the enhanced recovery protocol, and it gives specific information as to the intervention and who is responsible for delivery of that intervention. During surgery, we also adhere to particular principles, and this is documented within the brief operative note. There are specific information within the brief operative note that is protocol for every operative procedure. However, for colon resections, we also document other interventions that are part of the enhanced recovery, such as using multimodal interventions for pain control like anesthetic blocks. what types of interventions were used for normothermia, how we measured the patient's fluid needs intraoperatively, what types of DVT prophylaxis was used, if we gave the preoperative medications to prevent pain in our patients, antibiotic prophylaxis, and then again, hair clipping measures and wound protectors, as well as use of the closure tray. There is also a post-operative order set that, again, adheres to the enhanced recovery principles to allow for early mobilization, removal of tubes and IVs when appropriate, and allows for patients to get back to independence faster. Within the brief operative note, this is also mentioned at the bottom of the form so that all participants in the care team know the goals of care for the specific patient. This is my favorite part of the IT for our Enhanced Recovery Bundle because it provides feedback to the providers as to their compliance with specific measures and our outcomes. So we will talk about our specific outcomes, but by providing the providers with feedback in real time, we're able to demonstrate improvement and progress when we adhere to the enhanced recovery principles. So I'll now go through some specific measures of the value that we derived through this project. Our implementation of colorectal surgery ERAS demonstrates how compliance with standard process influences that positive change in outcomes for a patient population that we seek to gain. As shown on this slide, compliance with using the Cerner Power Plan, or that standard set of provider orders to be carried out for a patient undergoing colorectal surgery, has reached nearly 95% compliance rate, demonstrating the commitment by the surgeons to following the designated care pathway. Since initially gathering the project team in late 2016 to start this work, our average length of stay for colon resection patients has improved by a reduction of more than 3 days, excluding outliers. Of the 276 cases performed during the measurement period, 9 of these fell into our outlier category, or 3%, which were highly complex patients with length of stay greater than 20 days. Our surgical site infection rates were a major concern within the colorectal surgery population and is also a publicly reported measure for hospitals. In 2017, a Loyola study identified surgical site infections as representing 20% of all hospital-acquired infections, resulting in an average increase of length of stay by 9.7 days. Additionally, an article published in the American Journal of Infection Control in 2005 identified that there is an added cost of approximately $25,000 per case when a surgical site infection occurs. These infections are up to 60% preventable by using evidence-based guidelines. Through regular monitoring of our data, we were able to quickly recognize an unexpected uptick in infection rates in July of 2017. We quickly gathered the team, reviewed charts, and determined where our gap was. We identified education of our acute care surgery residents as being incomplete at the beginning of the new academic year. Our surgeon champions from the division were engaged and quickly addressed the gap. Our rates for surgical site infections subsequently reduced to 0 in the next quarter and have remained at less than 5 infections per 100 procedures since that time. Our project metrics included cost per case as a balancing metric to monitor for any increase in cost as a result of implementing the change. However, we discovered that our average direct costs during the inpatient admission phase of care has actually reduced by approximately $4,000 per case. This demonstrates that improved quality of care does indeed lead to reduced cost. 30-day return rate remains stable, and now that we've demonstrated sustained improvement with length of stay in surgical site infections, we intend to focus on reducing readmissions and further improving our post-acute care management, including leveraging partnerships and providing care management services throughout 90 days post-discharge. This is an important piece of work for us at VCU Health now because we've recently entered into the CMS Voluntary Bundled Payment Care Initiative for major bowel procedures. While we experienced a number of lessons learned throughout our project process, there are a few that we wanted to ensure we were very deliberate about sharing. It is the active engagement of both leadership and the care team that makes these projects a success. Without all of those participants being devoted to success of the project, we can't make the types of change that we've seen here. We also identified that keeping a patient-centric focus is very important. We noticed this with our surgical site infection monitoring through that identification that one of our divisions was not properly educated. So when we don't have widespread education and engagement, or we forget a small group of stakeholders, it can have significant impact. Monitoring data is crucial to sustaining new process and finding continuous improvement opportunities. So you can't measure what you can't see, and we make sure through our projects that we are able to capture important data points and monitor those ongoing. We also have discovered that this particular project has provided us with a template to standardize delivery of ERAS care principles across all types of surgery. And for the last 6 months, we've been working on implementing these care principles ubiquitously across our surgical care areas in VCU Health. So we thank you for your time.
We want to thank Dr. Bowl and Paula for that presentation and thank them for joining us for this webinar today. We also want to remind folks where to go find other Davies use case webinars and information on how to apply for Davies. That information can be found posted at the HIMSS Davies Award website at hims.org/Davies. That's hims.org/Davies. Thank you.